Hello and welcome everyone. Today we are discussing about uric acid levels. Uric acid is a final product of purine metabolism and is converted to allantoin in most mammals via uricase enzyme. The gradual accumulation of genetic mutations, mainly nonsense mutations in the uricase gene during the evolution process. This enzyme rendered undetectable in humans and specific monkeys. This causes the species to have higher urate concentration compared to other mammals. In humans, two-thirds of uric acid is excreted through the kidney and one-third through the GI tract. Uric acid levels in the humans are typically 2.5 to 7.0 mg per deciliter in males and 1.5 to 6 mg per deciliter in females. This table shows the uric acid levels in males and females. In males, the low level of uric acid is below 2.5 mg per dl and in female it is less than 1.5 mg per dl. Uric acid level is high if in male it is above 7 mg per dl and in female it is above 6 mg per dl. The summary of factors that influence the serum urate levels and their implications for human health are described here. These all factors affect the serum uric acid levels. They are race and ethnicity, genetics, comorbidities, medications, diet and culture, lifestyle factors, and gender. Low serum uric acid levels leads to reduced antioxidant levels and reactive oxygen species, free radicals, and oxidative stress leads to neurological diseases. When patients have a high serum uric acid levels, this leads to MSU formation and deposition. MSU is a monosodium urate. This formation and deposition lead to inflammation and it leads to gout. Gout leads to arthritic diseases and cardiometabolic diseases. Normal serum uric acid levels are optimal for immunoprotective and neuroprotective effects. Hyperuricemia may be divided into two major categories: symptomatic hyperuricemia and asymptomatic hyperuricemia. Symptomatic hyperuricemia is manifested by gout, nephrolithiasis, and uric acid nephropathy. The major causes of hyperuricemia are increased purine synthesis, inherited metabolic disorder, excess dietary purine intake, increased nucleic acid turnover, malignancy, cytotoxic drugs, and decreased excretion due to chronic renal failure or increased renal reabsorption. Hyperuricemia is commonly defined as serum urate concentration of 2 mg per dl or less. A low serum urate concentration may result from decreased production or increased excretion. In the most cases, the cause is related to drugs including salicylate, allopurinol, and X-ray contrast agents. Other causes are forced diuresis, total parenteral nutrition, several malignant diseases like glioblastoma, sarcoma, Hodgkin's lymphoma, etc. Increased urate production or underexcretion of uric acid can increase serum urate levels beyond the solubility threshold, accelerating the formation of monosodium urate crystals in and around the joints. The mobilization of MSU crystal could trigger an inflammatory response known as gout flares. The chronic suppression of uric acid level is a hallmark of reducing the MSU crystal burden and preventing future gout flares. Inflammation remains the principal aspect linking gout and cardiovascular diseases. Mechanisms whereby serum urate levels can contribute to development of hypertension are partly related to uric acid's primary effects on kidney. Although uric acid is predominantly eliminated from kidney, there is an evidence that uric acid crystal can deposit in coronary artery among the gout patient. The deposition of urate crystals in aorta and major arteries can associated with higher coronary calcium score and can trigger an inflammatory response. The mechanism responsible for blood pressure increase in hyperuricemic subjects is implicated both oxidative stress and intracellular urate activity. Let's see the methods to detect uric acid level in the laboratory. Currently, two methods are widely utilized to quantify uric acid. First is a colorimetric method. It depends on reduction of chromosome such as sodium tungstate by uric acid to produce measurable color change. Colorimetric determinations are generally considered an overestimation of true uric acid levels, and normal range is usually 1 mg per dl higher than the more specific enzymatic techniques. Second is enzymatic determination. It results from specific oxidation of uric acid by uricase, which converts its substrate to allantoin. The differential absorption of these substances at 293 nanometer allows the quantification of uric acid. So this is in short about uric acid, and these are the references for this video. Hope you like it. Thank you. Bye. See you in the next video.